So I'll start with a case. This was a 60-year-old man who presented with discharge from olecranon for about a month. He had stiffness of elbow for a long time, almost 1.5 years. And 5 months before he presented to us, you can see the X-ray. There is a large lytic area in the olecranon. A general surgeon did IND abscess. He was given antibiotics for 3 weeks, and after that, he was little better for some time, and then he developed a sinus. So 1 month before he approached to us, there was a sinus. 2 weeks before he came to us, the swab was taken, which was MSSA, and he was on appropriate antibiotics. Now this is how he is. He has a sinus, he has 2 incisions, has a flexion deformity of 30 degrees, and further flexion is up to about 90 degrees. His pronosupination is markedly restricted, and that's the X-ray presentation. There is a large lytic area in olecranon. The space between radius and humerus has decreased, maybe because of the positioning. Inflammatory markers were significantly raised. You can see there is an infection all around the elbow, the head of humerus, the olecranon. There is a sinus tract going down, as well as effusion and synovial hypertrophy in elbow. So this is where we are. Question is, what do we do? Do we continue MSSA? Do we aspirate and confirm the diagnosis? And if it turns out to be COX, it will settle with anti-TB drugs, or we operate. So how many for biopsy? Majority are for biopsy. So you think that essentially with anti-TB drugs it would help improve, correct? How many for exploration? Why would you explore? Why would you explore? Is there any classification system to give us guidelines? In elbow, there has to be some guideline, isn't it? Or I would like spine people say that it is essentially a medical disease. Yes, extraarticular also, extraspinal is also a medical disease. How do I decide when I operate? So in elbow, which will probably help management of other joints also, but elbow, there is an excellent paper by Mandeep Dhillon and all, a clinico-radiological diagnosis, and they have classified this, given guidelines when you operate and when you can conserve. So this was after analysis of almost 40 elbows, 38 patients, and the most common were olecranon or olecranon coronite junction lesions. This was a modification of Martini's classification, Dhillon's classification. So stage 1, obviously no bony involvement. That is the most benign thing. Stage 4, where the elbow is totally destroyed. In between, of course, you have a spectrum. So stage 2 is extraarticular involvement, that is either in epicondyle or olecranon, but not going into the joint. Stage 3A was extraarticular, but it's about to threatening to break open into the joint, and 3B is where there is an intraarticular involvement. So 1 and 2 are essentially not involving the joint. 3 and 4 are involving the joint. So the general roadmap they have suggested is, after confirming the diagnosis, ATT and physiotherapy for 1 and 2, stage 1 and 2. Stage 3, A as well as B, debridement, surgery, debridement and ATT. Stage 4, you can't really salvage the joint. But in case there is a problem, he has got a lot of pain, the sinus is not settling, then one can do the surgery. What were the results? Why have they classified this? So the results in stage 1, where of course there was only 1 patient, it's not all that common, was excellent. Stage 2, again extra-articular, not going into the joint, generally good results. Stage 3A, again it is threatening into the joint, but it is not broken into the joint. Good results. But moment it goes into the joint, the results were very, very not satisfying at all. 12 out of 17 had fair result. None of them had good result. And 5 out of 17 had poor result. So essentially, you have to see to it that the stage 3A does not go to 3B. And that is why you should explore. And in this particular case, obviously he had an involvement of the joint. So he did need surgery. Now what were their outcomes? First and foremost, they said that pronosupination, recovery of pronosupination is very poor. Only about 17 out of 38 patients had good, more than 90 degrees pronosupination. And many of them were painful. Not every day, but on exertion. So in this case, this we have already discussed. So as compared to spine, where stability is very important, here especially in upper limbs you need mobile joints. Maybe in foot you would need stability, but in upper limb, elbow, you need mobility. So in this case, whether it is COX or not, I have to explore. If it is septic, obviously I have to explore, and in COX, because of the lesion is 3B, I have to explore. So question was, how do I take an incision? So first and foremost, the sinus has to be included in the incision. Sinus tract needs to be excised, and then you need to go in. So this is, we have excised the sinus tract. Then you can see very often the sinus, the cloaca is very small, and then you tend to say that, oh, there is hardly anything inside. You must widen that opening. You can see the opening appears very small, but there is a large collection inside. There is a large collection inside. So this is after synovectomy. Histopathology was COX. We started 4 drugs, AKT, pan-sensitive TB. This is at 3 and 6 weeks. The culture grew. This is X-ray at 5 months. And this is at a year when we stopped anti-TB drugs. He has almost full pronation. But again, as discussed in the paper, there was hardly any supination. So essentially, the movements improved to a large extent, but he did not have fantastic movements. But of course, working wise, there was no problem. So general roadmap, 1 and 2, conservative, if operate only if they don't settle in 4 to 6 weeks or maybe longer. 3, surgery whether it is A and B. And 4, surgery only if there is a problem. Only if a patient has persistent sinus or very severe pain and you want to fuse. But otherwise, there is no need for surgery. Coming to tuberculosis of the foot, it could be a cavitatory lesion or a large defect. These are the most common things. This man presented with a sinus. You can see non-healing ulcer on the medial aspect of the foot going on for 6 months. But funnily, he presented not for that. He presented for a non-healing ulcer which had refused healing in spite of 2 skin graftings. That is why he had come. So he had very mild pain while walking, and when I examined him carefully, there was a sinus. So he has a sinus and an ulcer. Question is it TB? Is the ulcer tuberculosis? Is the sinus tuberculosis? So you can see this ulcer was certainly not likely to be TB. The TB ulcers are generally thin, bluish. Most important, they have undermined edges and a sort of pale granulation tissue. While here the granulation tissue was excellent. It was actually appeared to be fit for a graft. Still it had not healed. And so probably it was secondary to persistent discharge from the sinus. So we got an MRI done which showed a cavitatory lesion, and so I felt that with a sinus, with a large lesion which is likely to burst into the joint, he definitely needs surgery. The question is, what kind of incision do I take? As I said, it is always best to excise the sinus and then go in. This is a paper by Dr. Mandeep Dhillon, Sampath Dumre Patil and myself on role of surgery in management of osteoarticular tuberculosis of foot and ankle. So based on that, we excised the sinus and went in. You can see the granulation tissue popping out from that lesion which we scraped, and there was a large cavity in the talus, but the walls were quite thick, very strong. So we just probed everywhere and realized that the walls are very strong. It is not likely to collapse. So we decided not to do any kind of bone grafting. About skin graft, since we felt that this is a secondary ulcer, we did not do any grafting, skin grafting. This is at 2 weeks. You can see the ulcer has healed. That suggests that this was a secondary ulcer because of the this is at 6 weeks. The culture was positive, so we continued for drug treatment. This is at 2 years when he had no pain, doing jumping, running. This is at 4 years. He has maintained no recurrence, and that's the X-ray. The walls have really thickened well, and this is at 13 years when it's absolutely for 13 years he has had no problems at all. And you can see the cavity is totally reconstituted. Coming back to shoulder. Now this is a young boy, 15 months, has a discharging sinus in the right shoulder. For he had no pain, doing jumping, running. This is at 4 years. He has maintained no recurrence, and that's the X-ray. The walls have really thickened well, and this is at 13 years when it's absolutely for 13 years he has had no problems at all. And you can see the cavity is totally reconstituted. Coming back to shoulder. Now this is a young boy, 15 months, has a discharging sinus in the right shoulder for 2 months. This appears to be a tuberculous sinus. It just fits into the description. Now has a very funny history. Shoulder pain for 2 months. The X-ray showed lytic areas with facial irregularity, and the concerned person thought this is probably malignant. So he referred to Dr. Manish Agarwal, our oncosurgeon. He did a CT guided biopsy, which turned out to be the histopathology was caseous granuloma, and therefore he referred to a pediatrician who started him on anti-TB drugs, appropriate anti-TB drugs by a pediatrician. Unfortunately, the pain continued, and he developed a sinus 2 months after starting ATT. Initially, there was no sinus. After 2 months, he started ATT. So we repeated his MRI, which showed much more extensive lesion. Question is why? He has pan-sensitive disease. ATT was given by a good person with appropriate doses, and it is said that माँ भूखी रहेगी लेकिन बच्चे को दवा 100% ही देगी. They will cannot be defaulters as far as pediatrics is concerned. So what do I do? Do I explore? Do I start second line? Dr. Aisha, would you like to help us with that? Should I start second line empirically?
I think the first thing that we have to consider again over here is look at the patient, right? It's a young child, few months old. Look at the region that is involved. Yeah, it's the shoulder, it's the right shoulder. Oh, yeah, right shoulder. And in patients, especially young children, few months old, with involvement of the arm or the shoulder, you have to think of regional BCGosis. Yeah. Now, I understand that this patient had a report done elsewhere which was pan-susceptible, but I wonder if they had just based the initial ATT on a gene expert which must have shown RIF susceptibility, but not bothered to do an entire DST, which might have yielded a different picture. Okay. So I think you'll come to that.
So since the lesion had increased, we decided to explore. You can see this. And when you decide to explore, go all the way. Don't do a chota sa debridement. Do a thorough debridement. And here you can see the cavity which we have scraped. And again sent for everything. The gene expert was positive, no refi resistance, granulation tissue, and the pediatrician said, no, I mean, there could be resistance to something, some other drug. And he added moxifloxacin and cyclosin. And I said, what nonsense. What is he doing? Dr. Aisha.
So once again, when you're thinking of a BCG-osis, you have to remember that the, I'll come here, sorry. You have to remember that the BCG vaccine is created from M. bovis, Mycobacterium bovis. And
if you can come here and
sure.
face the crowd.
So Mycobacterium bovis typically is pyrazinamide monoresistant. It's sensitive to all the other drugs and pyrazinamide monoresistant. So remember this when you see a patient. It's a very unusual susceptibility pattern to find. But when we have seen pyrazinamide monoresistance, you either see it in a young child with BCG-osis, or rarely you see it in a patient who has undergone intravesical BCG treatment for CA of the bladder, yeah, which causes in some patients a regional or a disseminated infection. So this patient clearly had that.
Yeah. So what the pediatrician did was absolutely right. He suspected something. He added 2 drugs and it turned out to be pyrazinamide monoresistance. And it is, bovis is essentially resistant to pyrazinamide. We didn't do any grafting. Generally, children really recover very well. So this is at 9 months, has a decent range of movement, and is at 5 years post-op. Absolutely no restriction of anything, and in fact they got an X-ray done which was reported as normal. So you can see the bone, how bone can heal well. So friends, the take home will be always biopsy every lytic lesion. Don't take TB for granted. Do not, in case person is not settling, do not hesitate to repeat culture, do not hesitate to do resurgery, and finally do not underestimate the power of mother nature, especially in pediatric age group. Thank you, friends.